concrete picture of this LAM or learning alignment matrix, I deliberately place the concealed what is written there, because that is whatever I'm going to present. Whatever is written there are not yet really official, so I am not yet allowed to really disclose or present those. But something like that, there is name of qualification, the qualification code. Just to give you an idea, we already have level 6, which is the baccalaureate, because the Commission on Higher Education Technical Panel for PT Education is really in charge for it. So in that particular document, there are program outcomes, there are performance indicators per outcome. Also in that same document, the expected roles, the expected roles of a physical therapy student or graduate are listed. What are those? Clinician, educator, an advocate, a community-based rehabilitation practitioner, a manager, okay, and a researcher. So those are the 6 expected roles. So we will just be continuing this to level 7 and level 8. So each level, there is a specific set of program outcomes or practice outcomes. And again, there are performance indicators. We call the technical working committee agreed on calling level 7 as the specialized physical therapist, based from the, again, 6 roles that I have mentioned. And then the level 8 would be what we will be calling level 8 of our profession as the expert physical therapist. So those are, again, the current developments as far as the CPSP CATS is concerned. In the coming convention of PPTA, our chair, who is of course Dr. Escano, will be providing an update, because this coming weeks before the convention, I believe we're going to have a meeting spa. We're going to have meetings, so definitely the one that I'm presenting right now is just very superficial because I cannot divulge everything. During the convention, Dr. Escano most likely will be able to provide a more updated, more updates on this. Also, I'd like to report and invite also this one to the delegates that the Philippine Journal of Physical Therapy was also launched last July 2021, and this is our way of promoting a research evidence-based practice in the Philippines, that we should be science informed, evidence informed, okay? And we would want you guys, if you have your research papers, if you are interested, your dissertations, for example, you can submit that. We are now currently accepting submissions for our initial issue. So you can just visit the website of PPTA, and there is a tab there entitled Journal, and the journal will there's a link there that will direct you, or will redirect you rather, to the website of PHJPT. So you can also find guidelines there. I'd like to inform also the group, the delegates here, that we have just launched the 13th chapter of PPTA, which is the Southern Mindanao region, second in Mindanao. And we hope that other parts of the country will be inspired to have your own chapter. This will definitely make the transactions faster. This will help us propagate the information of what physical therapy is. We will be able to reach out with local government units as to isolated or local issues that we are facing. No, so the chapters are very important, and we hope that whoever, other parts of the country which are not yet not involved yet in any of the chapters here, you can start grouping yourselves at least at a minimum of 20 PPTA members. You just contact you can contact the national office, and we will definitely help you create this one. One beauty about having the chapters in the country, we are able to address, again, like what I've mentioned, we are able to address some of the issues in our respective localities. And in connection with that, we were able to mobilize our chapters to participate in the 3-day national vaccination program. So PPTA will be joining in this 3-day vaccination program as either a post-vaccinator, vaccination monitor, health educator, or a health screener. So if you are interested, those professionals here that are interested to be part of this effort of our government, you can scan the QR code here, or you can go to the link written in this on this slide, and please be part of this vaccination program. Because this is one of our goals, this is one of our roles, to be part of the public health awareness. We are also doing our involvement in other organizations, tying up with the Philippine Federation of Professional Associations. Probably next week, you will be receiving, all PPTA members will be receiving this resilience guide. So we are going to provide PPTA members a copy of this one. And then we are also involved in the Health Profession Association against COVID-19 and other issues related to public health, such as the use of vapes. International, we just had a partnership with Japanese Physical Therapy Association, and just watch out for our PPTA Facebook pages and other social media platforms for this partnership with the Japanese Physical Therapy Association. World Physiotherapy, we are continuously working with them, especially with their congresses, the World Congress and the different regional congresses. Rehabilitation 2030, the Filipino physical therapists are also present in this efforts of creating packages, and hopefully this will be translated in our country. I'd like to invite all our colleagues here to be part of this upcoming Impetus 2021. Yesterday we ended the early bird registration. Hopefully, even if it's already end, you can still find time to participate because registration is still open. So for other, I can see in the chat box also that the PAO-MPT officers are putting up links or indicating some links where you can inquire your, wherein you can inquire, yeah, sorry. Okay, so prior to that, there are 3 upcoming pre-convention workshops, one of which is a workshop by PAO-MPT entitled Using Sequential Partial Task Practice to Improve Clinician Technique Joint Mobilization and Manipulation. Okay, so please, this will be happening on December 3 as our pre-convention workshop. And lastly, I'd like to invite you guys to be part of PPTA. If you are not yet a member, there are so many things to do. There are so many tasks to do. Sino pa po ba ang magmamahal sa profesyon? Sino pa po ba ang magmamahal sa PT profession? Kundi tayo rin po. And as we centralize and collect all our efforts, our PPTA membership can be seen in our website. If you are a PAO-MPT member, you can also be a PPTA member, and PAO-MPT can facilitate your membership to PPTA. We started this partnership with PAO-MPT last year to somehow ensure the membership of PAO-MPT members to PPTA. That processes will be properly processes, or the process application members will be properly delivered to our office. So I hope you could be part of the growing professional organization, our PPTA. So these are the different social media platforms, website, and emails where you can reach out to us. And I'd like to take this opportunity to applaud all our colleagues who have been really dedicated and committed through this past years, months. It's a very crucial year for us. And despite all of this, despite of this pandemic, you are still there to continue your service in delivering in providing services to those people who are in need of physical therapy. Maraming salamat and keep it up. And your PPTA will always be here. And cheers for the future of the physical therapy profession in the Philippines. Mabuhay po tayong lahat.
Thank you so much for all the important updates, Mr. Michael Gabilo. And we would like to award a certificate of appreciation. So if you can please turn on your camera, sir, for the awarding. Thank you so much, Mr. Gabilo. So the certification reads, the Philippine Association of Orthopedic Manual Physical Therapists presents the Certificate of Appreciation to Michael Pereira Gabilo, PTRPD, HPED, as resource speaker during the conference entitled PAYAM 5th International Conference Game On Orthopedic Manual Therapy Unleashed in 21st Century MSK Care, held online via Zoom meeting on November 7, 14, and 21, and 2021, given on the 21st day of November 2021, signed by Lilian D. Bautista and Eugene Octaviano. Thank you once again, Mr. Michael Capilo.
My pleasure, pa. Thank you.
Sir Mike, thank you so much, sir.
All right.
You,
so to introduce our final speaker for today's conference, may I please call on Mr. Eugene Octaviano.
Good afternoon, good morning, and good evening to everybody. Our next speaker is a consultant musculoskeletal physiotherapist specializing in spinal conditions. She has been a consultant since 2006, providing care for MHS patients. Clinically, she manages patients with back pain, working closely with the spinal surgeon, directly listing patients for surgical intervention when necessary. She is affiliated to the University of Brighton as a fellow and an external examiner and tutor for the master's course, leading to membership to the Musculoskeletal Association of Chartered Physiotherapists. She completed her master's in manipulative physiotherapy in 2002. She has written a number of chapters in neuromusculoskeletal examination and assessment and principles of neuromusculoskeletal treatment and management. She is a reviewer for the Manual Therapy Journal. She was a member of the executive committee for the MACP and the MO delegate for IFOMP before stepping into the role of executive member of IFOMP in October 2012. And currently, she is the president of IFOMP. Help me welcome Laura Finucane.
Thank you very much, Eugene. That's a very nice welcome. So thank you. It's a real pleasure to be here. It sounds like you've had an amazing 3 days, lots of fun. And I was fortunate enough to listen to a bit of Rowley's presentation, which was excellent. So thank you. A very important role that we play within rehabilitation. So congratulations, really, really nice presentation. So and the last thing I will say, or would like to say, is that, you know, we, from an IFOMP perspective, we're absolutely delighted to have the Philippines as part of the IFOMP family. I know they're making great strides in becoming a member organisation of IFOMP, so really pleased that we have you as part of the IFOMP family. So I'm going to present to you on something that I feel very, very strongly about and feel very passionately about, and that's around serious pathologies that masquerade as musculoskeletal conditions. So I'm going to share you my screen, so just bear with me 1 second. There we go. Make sure we get on the right bit. Okay, just bear with me a second. There we go. So Brilliant. So as I said, I'm going to present to you around red flags, and I'm going to look at the evidence around this. But before I start, I want to really sort of give you a bit of context about why I've become interested and why I think it's really important that you as individuals, as physiotherapists, need to be cognizant and aware of serious pathology within your practice. I've been really fortunate to work with three individuals in the UK, James Self, Sue Greenhalgh and Christopher Mercer. And we've worked together very closely over the last over a decade now. And we've become very interested in serious pathology. And I'll tell you why, because I have a story that really sort of focused my attention on why we need to be interested or aware of these serious pathologies. And so we've got really two focuses around this. One is around making sure that we increase awareness around serious pathology and to consider it as a differential diagnosis. So it's really important that when you see your patients, you have a broad diagnosis or possible diagnosis. And if things aren't going in the way that you would expect, you might want to think, do they have something more serious going on for them? The second part is that we were really keen that we want to identify these patients early. It's really important that we pick these people up early because logically, if we can identify them early, then they do better. They have better outcomes, and in some cases, we can make a huge difference to the actual outcome and prognosis for them. But it's complicated and it's complex and it's not easy. We know that it's definitely not black and white. These individuals come with seemingly very musculoskeletal type disorders. So they do masquerade, and it is very challenging. And we'll talk about some of those challenges. But just to tell you a little bit about my story of why I got interested is a story about a lady who I saw, it's over 10 years now, it's probably about 15 years ago. This lady came to me with back pain and a radiculopathy. She had very clear signs of neurological dysfunction. She had no ankle jerk. She had reduced sensation and strength in her leg. She'd had a course of physiotherapy. And over that period of time, her symptoms were generally getting worse. And what she felt was that she wanted to have an intervention. So at that time, I was able to send her for an MRI scan. And the MRI scan came back as essentially normal. So I could not explain this lady's symptoms, her neurological dysfunction. So what I had to do at that time, I had to send her to see a surgeon and for them to do further investigations. And so by the time she saw the surgeon, which was about 2 or 3 months later, she had a tumor the size of a melon in her buttock, which was causing that compression of the nerve. And as a consequence of that, this lady had to have a hindquarter amputation. Absolutely life-changing for this lady, devastating for her. She was in her 60s, so it would be quite a life-changing experience for her and difficult to manage at that age. And of course, I felt responsible. I felt, could I have got this lady sooner? Was there a way that I could have picked this tumor up earlier? And at the time, I had a rheumatologist who was my mentor. And so we talked about essentially, you know, what could I have picked up something a bit sooner? And what we know about these tumors are that when I saw her, that tumor was probably the size of a pea. And so it'd be very difficult to palpate and to actually know that it was there. The 2 to 3 months that it took for her to get to see the surgeon, these tumors tend to grow very quickly. And they get more rapid and faster as time goes on. So hence the reason that by the time she got to the surgeon, it was that large. So whilst I may not have been able to influence her journey, what it made me think was, well, how can we ensure that we don't lose these individuals? So one of the good things that came out from this case was that we presented this case along with a few other cases to our radiologists and said, you know what, we need to be able to scan higher up and we need to be able to scan into the pelvis because we can make a difference to these patients quickly if we can do those tests. And so it changed our practice and we enabled ourselves to investigate these particular individuals. So that was really my journey. That was the start of my journey. And I know when I talked to Chris and Sue, they have very similar stories of why they became interested in serious pathology. So I'm going to talk about, this is essentially what I'm going to talk about. I'm going to talk about medicine is a science of uncertainty and an art of probability. So it is challenging. It's really challenging. It's not black and white. There is no recipe. It's something we're going to have to deal with. But we have a duty of care to our patients, and we need to make sure that we don't lose these patients. The second part of my story with this lady is also equally important. So I having seen this patient, I did lots of reflection on how I might do things differently. One of which was to speak to a consultant physiotherapist who was very experienced, much more experienced than I was at the time. And one of the first things she said to me was, well, I've never missed a serious pathology. And I thought to myself, wow, that would be amazing, never to miss a serious pathology. That would be just awesome. And in the next breath, I thought, well, how do you know that? We know that these individuals masquerade. You will miss serious pathology, and we cannot be arrogant enough to think that we'll never miss a serious pathology. They are, sometimes we may not even see these patients. We might see them in a part of the journey, and they go on to develop some of these symptoms, and you may not see them because of that. But what we want to do is try and ensure that you think about it and you're more aware of it. And then there's an opportunity to pick up these patients in the early stages. So I'm going to talk about why it's so challenging to identify these patients. I'm going to talk about that current evidence. I'm going to talk about the framework that I was involved in developing in 2020. And we'll talk about how we might put that into action. But before we go there, what I'm going to do is we're going to have a quiz. We're going to see what you know about serious pathology. So I've got 10 questions for you, and we're going to have a poll, and I'm going to ask for question 1 to be launched. Let's see what you know. So Lily, or can we have the first poll?
It's up, Laura. Are you not seeing it on your
No,
end?
I don't see it. Yeah. So yeah, I definitely don't see it. I'm hoping everyone else can see it.
Yes, we can see it. Maybe you're on a full screen on your Zoom, but we'll
I am
just
on a
give
full
you the
screen.
we'll just give you the results. It's up.
Okay, no worries. And you're probably going to have to tell me what the question was, because obviously I can't see them.
The first one is, which is the most common spinal pathology?
Okay. I'm going to see if I can just.
On the top, there's view
Yep.
options, you can do exit full screen if you'd like to do that.
I would. I'm just trying to find it. Yeah, I'm not finding it at the minute. Oh, sorry. Let's go back.
Can you also see the buttons on the bottom, like
Yep.
the participants, the polls?
So on top of my screen, yeah.
Okay. So maybe you can, if you want, you can launch it so you can see it. That would probably be the easiest way for the next question.
Yeah, it's not.
can-
Again, I can't. It's still not. I still can't see it. Don't worry. Let's try and if I come out for a second.
Okay. We'll try to end this poll, and then we'll see if we can see the results.
No worries.
Okay. I think we can end the poll now.
Okay.
Tech committee. Okay. Share the results. All right. Are you seeing it?
No.
Okay. Are the participants seeing it? Because I see it on both my screens.
Okay. Let me just. So now I can see it when I don't share.
Okay.
Yeah. Okay. Perfect. Okay.
Okay. All right.
All right. Let's. If I just do that, I wonder what happens when I do that. Escape. No. Yeah. Okay, right. So, which is the most common spinal pathology? Congratulations, those who put fracture. That is the most common. Perfect. Okay. So, should we go on to the next question? So, question 2. What is the percentage of serious spinal pathology? Looking good. A bit of mix of opinions here. Okay, so I'm going to end the poll. All right, so it's very interesting. In the literature, it talks about 1%. And we'll talk a little bit about that, but actually it's a slightly trick question here. There's evidence that's coming out that it's nearer 2%, and in practice sometimes we see 3%. So yeah, for those of you put 2 to 3, I think that's more realistic. Brilliant. So let's get rid of that one. And should we go to the next poll? So what action are you going to take if you suspect somebody that could have metastatic disease? Are you going to carry on and treat them and just watch how they go? Don't treat them and send them for an emergency referral. Are you going to begin therapy, or don't treat them and send them for an urgent referral? Okay, good. All right, so let's end that poll. Yep, so we're not going to treat these individuals, but we are going to send them urgently. They don't need to have an emergency appointment unless you think they've got metastatic spinal cord compression, but essentially an urgent referral. Brilliant. So let's go on to the next question. Oops, here we go. So a level of concern is determined by comorbidities, red flags, symptom progression, or all of the above. What's going to make you think this? I'm worried about this individual. Just give you 5 more seconds. Yep, good. Absolutely, all of the above. So there's lots of things you're going to need to think about, but all of those things are really important when we think about serious pathology. Good. Should we go on to the next one? So the top 5 cancers which are likely to metastasize to the spine are what? Prostate, lung, breast, bowel, kidney, prostate, lung, breast, thyroid, and kidney, breast, prostate, lung, thyroid, and ovarian. Okay, so let's stop it there. Okay, so the answer is prostate, lung, breast, thyroid, and kidney. So very important. Okay, next question. So red flags that are most predictive of malignancy are what? Is it a history of cancer, over the age of 50, worsening pain, or night pain? Okay, so let's end the poll. It's a history of cancer, and we'll pick this up a little bit later and we'll talk about the evidence around that. Brilliant, well done. Okay, so the next question. So what symptoms make up the classic triad for spinal infection? Is it back pain, weight loss, and fever? Is it fever, back pain, and night sweats? Fever, neurological dysfunction, and back pain? Okay, so we'll stop that. So it's basically fever, neurological dysfunction, and back pain. Well done. Next question. So the percentage distribution of metastases in the spine is is basically, what is it? Is it lumbar 20%, thoracic 60, cervical 20, or lumbar 30, thoracic 50, cervical 20, lumbar 20, thoracic 70, cervical 10? What do you think? Okay, so we'll stop there. So it is thoracic, it's basically lumbar spine is 20, thoracic 70, and cervical 10. So the bottom answer. Good. Okay, next question. I'm not sure how many are left, so you might just have to tell me. So, osteoporosis in women. So basically, osteoporosis is prevalent in what percentage of women by the age of 80? Is it 50, 60, 70, or 80%? Okay, well done. Okay, so if we stop there, and basically 70%, so it's very high, very high. But yeah, well done, that's good. Okay, and to the next one. So, what action should you take when a patient presents with bilateral leg pain but no cauda equina symptoms? Are you going to begin a course of therapy and safety net? Are you going to refer for an urgent MRI scan, refer for an emergency MRI scan, or discharge with exercises? Okay, so let's stop that one there. So basically, if they have no cauda equina symptoms, but they have bilateral leg symptoms, you can carry on treating them, but you need to safety net them. You need to tell them what to look out for. So well done. Okay. Do we have any more? Any more, Lily?
I believe that's the last one, Laura.
Perfect. Good. Okay. Well done, everybody. So bit of a challenge to get your brains thinking. So hopefully some of those things will become a bit clearer as my presentation goes on. So let me go back to sharing my screen. Okay. All right. So let's play concurrent. So I want to very briefly, I want to talk a little bit about COVID because you very rightly said, one of you said, there's been a very challenging year, almost 2 years. We've been really challenged by COVID, and we've had to do things very differently. And essentially what we know is that the impact of COVID has been really quite incredible. We've had, it's been the biggest pandemic of our time. It's, the last really big pandemic was the Spanish flu in 100 years ago, and we have very similar kind of patterns of how we've dealt with COVID, etc. But what's happened is that we've had to pause. There's been a real pause in non-emergency surgical procedures. The screening for cancers and other pathologies was paused, and essentially we know that 50,000 fewer people have been diagnosed with cancer or stroke or heart disease. We know that the modelling work around the COVID pandemic in terms of TB,
number one.
The modelling work around TB over a 3-month period has shown that disruption has we're likely to see an increase in TB by about 13%, which means that the mortality rate is going to be take us back 5 years in the way that we've progressed with TB. We know that there's been a shift to remote consultations, and which has been really challenging for us as individuals. So for a clinician, there's been an assumption that face-to-face is the same as doing a telehealth. Well, it's not. It's very different. It requires a very different set of skills. And when we see our patients face-to-face, we use lots of our senses. We see them walking in, we see them with a slight limp, we can see that they're sweating, we can see that they might be wringing their hands and visibly sweating. So in order to address that kind of lack of data, often what happens is that we become quite anxious about, well, am I missing something? Do I need to do something a bit more? So it's quite challenging. We know that there's been a change in health-seeking behaviour. So lots of people shied away from making appointments with their GP, or their experience was that their general practitioner was too busy, and that a referral that might have been made initially wasn't being made. They stopped going to A&E.
Wait there, you wait there.
Hello. To stop going to A&E with symptoms that could have been related to other pathologies. And so we know that particularly in where I am in the UK, that the emergency admissions really was reduced by about 30% over the period of time of COVID, which is huge. But these patients are still having heart attacks, strokes. They still have symptoms of cancer, but they're not presenting in the same way that they would have done outside of COVID. We know that what that means is these patients are likely to present late in that diagnosis, and we're going to see more of those cases probably as we come out of the pandemic. There's going to be more people seeking help, but what we'll see is those patients with much franker signs and symptoms of serious disease. So, and we also know that patients were more worried about catching COVID when they went to A&E or to the GP than their actual symptoms of serious pathology. So again, it's really difficult, and some of these actually are very similar. So if you look at something like the COVID symptoms, what we know is that actually they're very similar to something like lung cancer or TB. And so it's that challenge of how do you unravel these individuals to make sure that we're picking them up. We had a young gentleman who came to us with back pain and leg symptoms, and we suspected he probably had spinal infection. And he was sent to A&E on the basis that we needed to get him sorted very quickly. And what happened when he got to A&E was he was put on a COVID ward because he had a fever, he had a cough. And so the assumption was, well, you must have COVID. And so that was really challenging. Eventually we got him to the right place, but it was really difficult because it was just this focus on COVID and not thinking about the broader picture in this instance. We might find that going forwards that we might actually see new serious pathologies. We don't know, but one thing is we feel that we might see more spinal infection. That's highly possible with the viral load. It's a possibility, but we must be prepared for that. We must think about, what are we going to see as we go forwards. So I was involved in a framework to help clinicians really think about these patients who might present to you with serious pathology. What we knew at the time, when we started this journey on the framework in 2016, we knew that there was anxiety in the system, that our colleagues, our physiotherapists around the world was really just quite concerned about what happens if I miss a serious pathology. I don't want to miss a serious pathology. I think there are, particularly in parts of the world where advanced practice is very common, there is this anxiety that I'm in a role where it's more likely these patients might present. But also I would argue that it doesn't matter who sends you that patient, where you see that patient within that journey, whether it's the general practitioner that sent you the patient or the orthopedic surgeon. We can't be reassured that they have asked the red flag questions. They may well have asked the red flag questions. They may have explored that with the patient, and they may say, this patient does not have any serious pathology. And that may well be the case at that time in motion when they saw that clinician. They had nothing that was suspicious. What we know about these serious pathologies are that they change over time. They evolve over time. So it's not helpful just to think, well, it's been sorted, it's been checked, and I don't need to worry about it. We need to evaluate every single time we see these patients to really check that if I'm treating them for something, is it going in the direction I want it to? Is it really behaving in the way I would expect that particular pathology to respond? Because if it isn't, then I need to be thinking, is there something else going on for these individuals? So it's really important that we don't just accept from our colleagues that there is nothing in terms of red flags. It really is, that's really critical. So so what's the problem? We knew that if you look at the literature, there's really no agreed definitions around which red flags for what pathologies essentially, or what a red flag is. We're told very clearly that it's rare, and therefore we shouldn't really have to worry about this. We're told that it's got a poor diagnostic accuracy. So in other words, if the red flag is present, it means that it's likely that this individual has got a serious pathology. But we have a handful of red flags that have good diagnostic accuracy, but it's not particularly helpful. There is no consensus on which red flags we should use for which serious pathology. And there are no agreed guidelines on when we should act, should there be a serious pathology actually present. So as a consequence, over the last 5 years, there's been a really a call to question about why we're bothering to use red flags, because basically they're not really helpful in clinical practice. I really like this top quote, which says the formulaic use of a red flag of past history of cancer is too blunt an instrument to be used in routine practice without considering the type of cancer and how long ago it was diagnosed. And I completely agree with that. It's about context, and what's going to be really important is understanding about that past history of cancer. Why would a specific cancer make me worry? And again, we'll pick this up a bit later. So there's been lots of criticism around the use of red flags. We also know that specifically that just because a red flag isn't present doesn't mean that this individual doesn't have serious pathology. So it's really difficult to navigate and to say, yep, that makes me think that there's something going on for this individual. So when does a red flag become a red flag? I think we have very much concentrated on clinical features. We talk about weight loss or night pain, etc. But actually what's really important is we consider those risk factors that an individual may well have when they come and see you, because that will help to add to the picture that you're seeing in front of you. So we need to consider, is this patient at risk of developing serious pathology? And a really good example of that would be somebody who has a past history of cancer. It's a risk factor. It's not something that I would go, well, they must have cancer, because they won't always have cancer. You need to understand the type of cancer, and you need to understand the likelihood of that cancer metastasizing to the spine. And then it's thinking, well, yes, they might have a past history of cancer that's relevant that could metastasize, but they have no other features. So it's about combining those things to make sure that we have this full picture. And so what we wanted to do was to really work on something that was really helpful for clinicians and for you to see the same thing. So if you think about red flags, often what you see is this list of items that you have to decide what to do with. Your interpretation is going to be different to my interpretation, and how you see it will be very different. So what we want to do is, some of you will see this is a bird, and some of you will see that this is a dog. But actually what we really want is for you to go, right, if I see this, then this is what I think. And everybody is saying the same thing. We're all interpreting it in the same way. And that was the purpose really of the framework. So let's talk about how rare is it? Well, when we talk about serious pathology, we're often told, I don't know why you're worrying. It's 1% of all those musculoskeletal conditions you're going to see. Well, I think if you think about 1%, 1% is 1 in 100. And I would argue that that is not insignificant in itself. So you only have to think about how many patients you see in a week or how many patients you see in a month. And it's likely that you're going to pick up at least one serious pathology in a month. So it's not insignificant. It will, of course, depend on where you sit in that pathway. So we know that general practitioners see less serious pathology than a spinal surgeon. Hello. So you're likely to be sitting somewhere in between those two areas. And so it's important to understand, what you might see. We also know that our population is getting older. And what we know is that often serous pathology is associated with older age. We know that the treatment of primary cancers is really improved, and it's improved survival rates. But what that means is that we will see more metastases and different types of cancers as these patients get older. We also know that those with a chronic musculoskeletal condition are about 20% more likely to develop a morbidity such as cancer, stroke, diabetes, and cardiovascular disease. So it's important that we understand what's going to happen to our population as time goes on. We also know that, as I did in the quiz, that actually there's some really, really strong data coming out from the Denmark group, who basically have shown that actually it's more likely to be nearer 2%, that you're going to see about 2%. Well, 2% is 1 in 50, so it's absolutely not insignificant. And so we need to be aware of that in terms of the numbers that we might see. So for me, diagnostic accuracy. So we as a profession, understandably, we want to be evidence-based. We want to make sure that what we do is supported by the evidence. And in order to justify the use of red flags, what we've tried to do is to establish diagnostic accuracy. So when that red flag exists, it increases the likelihood or probability of serous pathology existing. And of course, we've not really been able to do that, which isn't really surprising, because if you look at the typically low prevalence of serious diseases in our populations, it weakens the overall predictive value of that diagnostic test, the red flag. So for example, if you take spinal infection, there is an incidence of around 0.2 to 2.4 cases per 100,000 annually in a Western society. So this low incident rate makes it almost virtually impossible to do prospective diagnostic studies. So what you end up with is lots of case studies, case reports, and retrospective cases, which of course does not allow us to do diagnostic accuracy data, to get data from it. So it's really hard. We know that there are a certain number of red flags that do have diagnostic accuracy, and of course one of those is a past history of cancer. So we know that when we talk about a past history of cancer, that could be a very broad number of cancers, but actually what we know is that we have to be more specific. So whilst a past history of cancer increases the probability or the likelihood of someone having serious pathology, it only increases it by about 7%. It will depend on the type of cancer. So in the quiz, we talked about what are the top 5. So breast, prostate, lung, thyroid, and kidney. They're the most likely ones that are going to metastasize to the spine. Now, not all of them will metastasize to the spine. So about 30% of those with those top 5 cancers will go on to metastasize. So it's important, again, that we don't just go, right, this person's got a past history of breast cancer, they must have metastases, because that's not the reality. The reality is we just need to be aware that that is a possibility. And we are not going to act on that one red flag. That's impossible. So you might have a patient who comes with ovarian cancer. It's less likely to metastasize. It has a low likelihood of metastasizing to the spine. So again, my threshold would be lowered, but I would be thinking about all cancers. I would be concerned, but the top 5 are the ones that would worry me most in terms of back pain. We also cannot be reassured by the absence of a past history of cancer. So I might have somebody who comes into my clinic and they have no evidence of cancer. What we know is that we're picking up around 25% of individuals who have an unknown primary cancer causing their back pain. So they've got metastases, but they don't have a diagnosis of cancer. So we can't be reassured by that absence of that cancer itself. So it becomes challenging. Some of the work done by Ariana Verhagen essentially identified 13 red flags were associated with metastases and malignancy, with past history of cancer being one of those, and a strong clinical suspicion. And so this is really important. So what do we mean by a strong clinical suspicion? Well, what we mean is that you're looking at these individuals and you're asking the right questions. You have experience and you have some curiosity, and you understand how some of these serious pathologies actually play out over time. And you put that into the context, which gives you this combination. So sometimes we talk about this gut feeling. We talk about, I think something's going on here. But actually, all of that feeling is based on all of these things, that you've asked those questions, you've got experience, and you've seen it somewhere else, or you've heard it somewhere else, and you've been more curious about it, and you started to ask those questions. All of that will be extremely important in identifying these individuals. When we look at the guidelines, we have a real conundrum here. Guidelines are developed because there is generally new evidence. And so the guidelines really produce the new evidence, but they bolt on those red flags because of safety and because it's a bit of a defensive medicine, and nothing's really changed in terms of red flags. So it's not always very clear of why they are in these guidelines. And there are two schools of thoughts. One is take them out of the guidelines, don't even put them in. It's pointless. You just need to think about your differential diagnoses. And that's really challenging. It's okay if you know what those are, but if you don't know what they are, it's not helpful. And on the other end, we have guidelines that suggest we should act on a single red flag. Now, of course, that's not helpful either, because every sort of 80% of the patients you see that come with back pain will have at least one red flag. So it's really unhelpful to have that. And so it's really important that we really consider what those guidelines are telling us and how we can use the guidelines to inform our practice. We also know that it's not helpful if we send our patients off to have unnecessary, inappropriate tests and procedures, because it's worrying for the patient, and it's just not, we underestimate the impact it will have on those individuals. So we've got to be mindful of that, the impact it will have if you start suggesting, oh, I think you might have serious pathology, or I'm just going to do this because I'm worried you could have serious pathology. It has to be based on your clinical reasoning. And so that brings us really into, where does that leave us? Well, we've got to agree those definitions. We do have to stop relying on diagnostic accuracy. It's helpful, but it shouldn't be the only thing we think about. We need to have a consensus on which red flags for which serious pathologies and agree guidelines on when we should be acting. And so this brought us to the framework. And so what the framework does is it doesn't provide you with a recipe. It's not a set of rules or algorithms. What it's trying to do is to help guide you to think what questions you need to ask that individual when they answer, yes, I've had a past history of breast cancer or prostate cancer. What's the next question that you need to ask that will help you make a decision about where you need to go next? Now, I'm sure you may have seen this. It's been published. It was published in 2020. And essentially what it does is it lays out the risk factors for someone who potentially could have spinal malignancy, for example. And that so if we look at this, what it does is it asks you, well, is it one of the top 5 cancers? Do I need to ask them about that? What's that predilection going to be, etc. So it's really important that we ask those questions. How long was your primary cancer diagnosed? How big was the primary tumor? Was there lymph node involvement? Which treatment did you have? Because all of those things will help us understand whether this was an aggressive cancer or not, and therefore, do we need to be concerned? It then talks about what your patients will tell you. Subjectively, what are they going to tell you? So a good example of that is night pain. I'm not worried about those individuals who tell me, yeah, the pain wakes me up at night. I have to get up and I have to walk the floors, but I go to the toilet, I come back and I can get back into bed and I lie down and go back to sleep. I'm not worried about those individuals, but I am worried about that individual who tells me I can't lie flat. I have to get up, I have to walk around, I take medication, it doesn't make any difference, or I have to sit up in the bed or sit in a chair to sleep because I just can't lie flat. Then that would worry me. And of course, then we have their objective signs. So these are things that you might see on your objective examination. But what we know about the objective examination is that often they don't present with objective signs until the late stages of the disease, particularly in respect to malignancy. So again, it's putting it into the context of, how helpful is that test for me in the framework. And so what you have to do is you have to determine that level of concern. You have to pull that evidence together, and you have to look at it in the context of that patient. So you have to consider whether the individual is at risk for the presence of a serious pathology. And that's about combining the evidence that supports those red flags. It's using the determinants of that individual, and then really making a consideration about, what do I think? Do I think I'm concerned about this individual? And so the next step is, what are you going to do? What's your decision? Where are you in this model? So you might have a patient who has no concerning features, and you carry on treating them, but you must evaluate them, continue to evaluate them. Know that I would expect the natural history of back pain should last this long, but if it's not going in the way it should do I need to revisit those red flags? Do I need to consider it? Have they got these few concerning features? They might have a past history of cancer. It's a concern, but it's not enough for me to actually send them to be investigated. So I'm going to keep an eye on them. I'm going to watch and wait, and I'm going to see how that plays out, because we know that things like metastases will tend to do this, go up and down over time. We know that spinal infection has a linear progression. So it's important to understand those things. You might have somebody who's got some concerning features, and the difference between the orange and the red is the urgency in which you're going to send these individuals. So for someone who has concerning features such as metastases, that's an urgent referral that you're concerned about. Whereas someone with Cauda-Equina syndrome or metastatic spinal cord compression, that's an emergency. So it's important to understand that, and to understand how your pathways might look like in terms of dealing with these individuals. And so it is about asking the right questions. You have to understand what those risk factors are for each of those pathologies. And if you have some knowledge around those serious pathologies, you can really add that to your patient investigation. Use the red flags, they're there for a reason, but also safety net these individuals. It's really important that we empower our patients to take responsibility of their symptoms. And so what we want is for you to all see that this is a dog, not a bird, and that we translate all of those items in the same way. So just to put that into a little bit of context, what we know about spinal infection is there are a number of risk factors, and these are some of the key ones. So somebody who is immunosuppressed, there's lots of things that will suppress your immunity system. Diabetes is one of them. Surgery and invasive procedures is a risk factor. Older age, and particularly in men, they are the risk factors of spinal infection. We know that we talk about this clinical feature, so this classic triad. So in the questions I gave you, essentially fever, spinal pain, and neurological dysfunction makes up the classic triad. Well, fever in itself is not helpful because it's absent in 50% of individuals who do have spinal infection. So we can't rely on it, but from a clinical point of view, it's helpful to know it. So if I look at a case study, so this individual was seen by two people. One was a physiotherapist who treated this gentleman and was later seen by the advanced practitioner. And subjectively, what the physiotherapist found was that this was a 43-year-old male, a smoker, living in the UK for 4 years. He described himself as a manual worker, and he had a history of low back pain and thoracic spine pain. He described this band-like pain, and it was quite intense, 6 to 7 out on the VAS score. He had no leg pain, he had no red flags, he had no fever, no weight loss, no night pain. When the advanced practitioner saw this gentleman, what she added to this presentation was that this gentleman was born in Somalia. Somalia is a TB endemic country. He worked mainly on a farm as a farm worker in Spain. And at the time, at the onset of his symptoms, he had a very high temperature and fever right at the beginning. He was very tired. He described himself as very fatigued, and what he did to manage that was to take himself to bed for most of the day. He had normal blood tests, but he did have very progressive pain. On objective examination, the physiotherapist On examination, found that this gentleman had quite a significant kyphosis and he had this band-like pain. He had very limited extension and this was very painful, but he had a normal neurology. The advanced practitioner found, added to the presentation, he had positive percussion. So in other words, as she tapped down the spine, it hurt quite significantly where the TB was. Okay, and they also had a cough response that was positive. And what we mean by that is when the patient coughed, they reproduced their symptoms, but they had like an echo effect. So the pain went up and down the spine for some time just after they coughed, so quite significant. And they had absolutely no active extension. So when we think about this and we think about those red flags and those reassurances we have with this individual, what we see is this. The risk factors: he's male, he was born in a TB endemic country, he was a farm worker, he's a smoker. Smoking will reduce your immunity. He's got a fever, high temperature at the onset of his back pain. He's got this band-like pain. He describes this fatigue. He talks about progressive pain that's getting worse and not responding to treatment. But we are reassured by no leg symptoms, no neurology, normal blood tests, and no fever at consultation, and his weight is stable. But on balance, if we look at those things, we can see that actually this is really significant. Those risk factors added to some of those symptoms really make it significantly feeling like there's something going on for this individual. And this individual did have TB. He, as you can see, hopefully you can see on here, but basically he's got between T10 and 12, he's got this infiltration destruction of the vertebral bodies, particularly around T11, and he's got this abscess as well, suggestive of TB. And unfortunately, this gentleman, because he tried to manage his symptoms over a period of time, he really didn't do very well. This gentleman died a few months later because he hadn't been managed effectively. So it's really difficult, but what we knew was that actually when you look at the red flags and you look at the evidence, we know that it's really important to consider the risk factors, not just the clinical features. What we found within our framework was actually the risk factors were much more sensitive than and had a more predictive value in terms of that serious pathology than actually looking at some of those clinical features. But the combination of both of those things are really, really important. We know that it's really challenging. You have a daily challenge of managing diagnostic uncertainty. We aren't always sure about what's going on for those individuals. And it's not cost effective to approach with no risk. We would be scanning everybody. We know that that's not appropriate and it's not helpful for individuals. And we know that actually when you scan people, there'll be changes on those scans that really are not relevant to this individual. We know that if we have too high a risk, that can lead to missed cases and late diagnosis and possible avoidable death. So we have to find this balance, and it is really, really challenging. And I don't know, but certainly what I see in practice is there's an increased complexity around individuals, and sometimes it's not easy to come up with a diagnosis. And sometimes you think, yeah, I've got it. I know what that diagnosis is, and it looks a little bit like this. So boom, you've got it in the bag. You know exactly what's going on. It's done. Boom. But actually, in reality, what can happen is this.
Dash to the steal by DeRozan. And he spins it.
So you think you've got it in the bag, but actually what happens is the patient tells you something else, and you suddenly realize, wow, that puts a whole different spin on this individual. So it's really important that we think about how we're going to manage these individuals. We're going to have to listen to those stories. And we need the patients to be really help us do that. Oh, sorry. So when we talk about how do we manage this uncertainty, we need to make sure that we communicate that uncertainty to our patients. but in a reassuring way. It's not about scaring our patients. Sometimes the story is not clear cut, and we need time for it to develop. And we might need to say to our patients, hey, right now, this is good, we're all good, this is what I'm seeing, I'm reassured by these things, but I want you to keep an eye out on this and this. And a really good example of that would be would be called Equine syndrome, where they might come to you with bilateral leg symptoms, but no cord equina symptoms. For that individual, I want to safety net them. I want to say to them, yeah, you might have there's a very small chance you might develop cord equina syndrome. It's really rare, but actually what I want you to do is I want you to look out for these signs and symptoms. It might come quickly, it might take a few days, it may not come at all, but you need to know what you need to do should you develop those symptoms. And then in some cases, I might want to follow those patients up, but essentially they're empowered. They understand why they need to go and seek help, because it's really important that they do that. We can't be with them 24 hours a day as things change. And so the consequences of uncertainty are that we can become less tolerant. And that can lead to increased diagnosis or diagnostic tests, which, as I've said, is really unhelpful for some individuals. There might be worries around litigation. So this is something in the UK that we've seen an increase in, and something that we're very mindful of. We know that it can be, if you're uncertain about a certain pathology, then it can be really distressing for you as an individual. And so, that can lead to burnout. If you're worried all the time, you're taking your patients home with you because you're continually worried, it's really unhelpful. And it can, of course, be a source of distress for patients if it's not done in the right way. So we really don't want to be doing tests because it's helpful for us as clinicians. We need to be doing those tests because it's relevant for those individuals. And I'm not going to talk too much about litigation in this presentation because it's not something we need to be concerned about. What I want you to be concerned about is that often it's about recognizing that the red flags that are associated with these non-musculoskeletal pathologies will be really helpful. It's about considering that differential diagnosis and making sure that you're documenting that is the case, that I've checked those things. I know that they don't have these signs and symptoms at this point in time is really helpful. If we don't do those, if we do those things, then we will protect ourselves. And I think, as I described when I talked about safety netting, essentially this is about picking up those patients who might run into difficulty of some serious pathology is a helpful way of looking at it. But for you, it's really important that you put things in place to support yourselves in how you recognize, how you deal with that uncertainty. Some of you will be brilliant. Some of you, it won't be a problem at all. You will have strategies in place, but it's important you put them in place. So my strategy around dealing with uncertainty is that I have a really good support network. I speak to my mentors, I speak to Chris and Sue regularly about cases. And so I can actually sort of talk about how that plays out. And often that's all I need is to say, hey, I have this case. I'm a bit worried about it. Can I talk it through? And as I talk it through, it becomes really clear about what the next steps are going to be. You need to be kind to yourself. It's about reflection. It's about mentorship. It's really important that you support yourselves, particularly if you're working in a lone practice. You need to surround yourselves with individuals that can help support you as you go forwards. So what we do know is that serious pathology is likely to increase. We know our population is becoming older. We know that the impact of COVID might change how we view these individuals. We know that early identification is really important. We need to understand a patient's health status. That's really important. How healthy are they? Do they have risk factors that I need to be concerned about? And if you can understand how a serious pathology behaves, so if you know that someone with malignancy, it does this, it waxes and wanes, and you know that spinal infection progressively gets worse, then that's really helpful for you. Because ultimately, we can make a really big difference. You are in the best place to help these individuals. We can make a huge difference as physiotherapists and really help these individuals get to the right place as quickly as possible. I just want to leave you with a short video that was created by Sue Greenhalgh. And basically, this was really to do with the pandemic. So over the pandemic, we noticed that there were fewer people attending A&E. We saw fewer people attending physiotherapy, etc. And we wanted to make sure that individuals would be aware, we would empower these individuals to take some responsibility and to look out for certain symptoms that we would consider as needing a really urgent help. And so I'm going to leave you with this video. Hopefully. Oh, she says, oh, I'm not. I might have to go and find it. So bear with me. I'll see if I can find it. And I'm very happy to take any questions as I try to find that video. It's not in that one. Okay. Can you still see my screen?
Not yet, Laura.
You can see it or you can't?
We can't. We can.
You can. Okay, good. Okay, so let me just.
Laura, you could share your
specific or mechanical back pain. It's not serious.
We cannot see it. Cannot.
Okay. All right. Just one moment. Let me come back. Okay. Here we go. Just go back to the beginning. Can you see it now?
There, yes.
Okay.
Thank you.
Most back pain is called non-specific or mechanical back pain. It's not serious and often gets better on its own with an active approach. Urgent help for mechanical back pain is not needed. Very rarely, back pain has a serious cause, which can be helped more effectively if found early. Certain symptoms can suggest that the cause of your back pain could be something more worrying, and an urgent opinion from your healthcare professional may be needed. It's important that you know what to look out for and what to do if these symptoms develop, and very importantly, when. The following symptoms require an urgent opinion, but it's not necessary to seek help the same day. Back pain that's getting worse, severe, and different to that you've experienced before. Pain that spreads from your back in a band around your body. Odd feelings in your legs with a feeling of unsteadiness, difficulty walking, and heaviness in your legs. Back pain that stops you sleeping at night or gets worse when you lie down. Or fever or chills since the onset of your back pain. Sometimes, but very rarely, your urgent appointment will need to be at your emergency department the same day. Look out for back and leg pain and any of the following. If these symptoms develop, seek help immediately. Loss of feeling or pins and needles between your inner thighs and genitals, or numbness in or around your back passage or buttocks. Altered feeling when you use toilet paper to wipe yourself. Increased difficulty when you try to urinate. Leaking or difficulty when you try to stop or control the flow of urine. Not knowing when your bladder or bowel are full or empty, or loss of sensation when you pass urine or stool. Or a change in ability to achieve erection or ejaculation, or loss of sensation in your genitals during sexual intercourse. Other things can cause these symptoms, and serious spinal conditions are very rare. But treatment is much more effective if the condition is found early. Help us to help you. Look out for these symptoms, and if they develop alongside your back pain, seek urgent help from from your healthcare professional.
So, thank you.
All right, thank you very much for really enlightening presentation about red flags and what things we should be considering. I actually have a few questions here, Laura, that we might need some your professional opinion. The first one is actually asking, how do you communicate your clinical opinion when you see it's a red flag or you suspect it's a red flag to the patient? Or do you just refer them out immediately and let the physician tell them this information?
So, so in my world, I would talk to them about it. I think it's really important that we talk to patients very openly and transparently about what we're seeing, and that doesn't mean that we need to worry patients, because actually, my experience is that if you ask the patient, if you use the concept of ICE, which is ideas, concerns, and experience, then actually, when I ask the question about, do you have any concerns? Are you concerned about your back pain or your condition? Then sometimes what you'll get back is, yes, I am worried. I am worried about my symptoms. Why are you worried? Because I think I might have cancer. And some patients are very upfront about it, and they will say, I'm worried about what might be going on. And it might be because their next door neighbor also had back pain, but it happened to be cancer. And so they might be thinking of someone else's experience, or they may actually generally think, well, I've had a past history of cancer. I know that there is a chance that that can metastasize. And so I will answer those questions and I will say, right, so this is your story. This is what you're telling me. These are the things that reassure me.